Morning everyone. Today's micro teaching session is about photoimmunotherapy. Photoimmunotherapy basically combines photodynamic therapy and immunotherapy. Photoimmunotherapy is an oncological treatment that combines photodynamic therapy of tumor with immunotherapy, and the dynamic therapy was developed by Julia Levy and her colleagues at University of British Columbia in 1983. And most recently the immunotherapy part was added to it by the team of Professor Kobayashi and at the National Cancer Institute in Bethesda, Maryland. Conventional photodynamic therapy uses a non-specific photosensitizer which can be activated by non-ionizing light to kill cancer cells. Photosensitizers are molecules that rapidly destroy cell through production of reactive oxygen species when they are exposed to a specific wavelength of light. However, photodynamic therapy can also damage normal human cells because these sensitizers are non-targeted and they are taken up by normal cells as well. So to alleviate this problem, the Kobayashi team developed targeted photosensitizers. These involve two components: a monoclonal antibody which recognizes specific proteins on the surface of cancer cells, and a non-targeted photosensitizer. Photoimmunotherapy previously, a vast number of photosensitizers were developed, some of which are porphyrins, chlorins, and phthalocyanins, and the Kobayashi team coupled these photosensitizers with the monoclonal antibody targeting human epidermal growth factor, and they used a soluble phthalocyanin dye. This dye, phthalocyanin dye IRDY700DX, was chosen because of its hydrophilicity and strong cytotoxic effect. A variety of cancers such as breast and pancreatic cancer overexpress this epidermal growth factor receptor, and this immunotherapy was studied on these types of cancers only. In vitro studies showed that the monoclonal antibody IR700, 700 being the wavelength of infrared light used, killed tumor cells within seconds after the near infrared light irradiation. There was also positive correlation between the intensity of excitation light and percentage of cell damage. Infrared light alone or monoclonal antibody alone did not cause any damage to normal cells. When tumors immunografted mice were treated with monoclonal antibody IR700 and near infrared light, significant tumor shrinkage was observed. With fractionated administration of monoclonal antibody IR700 conjugate followed by systematic repeated near infrared light radiation, 80% of tumor cells were eradicated and the survival was significantly prolonged. Based on the current hypothesis, cell death induced by photoimmunotherapy was caused by rapid expansion of local water upon the formation of holes in the membrane. Another desirable feature of photoimmunotherapy using this conjugate is that it also emits fluorescent light, so we can monitor this fluorescence and see where the drug is actually acting, and also the tumor burden can be monitored over time. Because of reduced fluorescence, it will indicate that the tumor burden is reduced as well. Therefore, photoimmunotherapy can be administered as at a lower dosage to guide application of excitation light to tumor tissue, further minimizing unnecessary light exposure to surrounding tissue and preventing its damage. Thank you.